There's one thing and only one thing that assisted suicide and modern fit-for-purpose palliative care have in common. That's that they're both really poorly understood. In 2021, an online survey asked the public what they understood by the term assisted dying. 10% said hospice type care, 42% stopping treatment, and only 43% got it right, giving lethal drugs if somebody is thought to have less than 6 months to live. I think that's particularly worrying because it's well known that it's people who think they know something about a subject who tend to respond to such surveys. I think there's even more confusion now, some of it generated by misinformation. Let's turn to the semantics of what's often called assisted dying. They're not straightforward because they've evolved over time. They're often used differently in different countries, and they tend to be used very loosely. At present, the terms assisted dying and assisted suicide have become almost used interchangeably and are currently both used to describe the oral or intravenous administration of lethal doses of drugs. I think an easier way to think about it all is to divide it into physician-assisted suicide and physician-administered euthanasia. So the former involves the prescription of a cocktail of a high-dose lethal drugs that the person swallows at the time of their choosing. Physician-administered euthanasia is the injection of a different mixture of different drugs at high doses that's also lethal. You die much more quickly by the injection regime than by the oral regime. And with the oral regime, the time can vary greatly from dying within minutes, and the longest reported is up to 4 days. Although a really important and worrying aspect of this is that in the countries where this has been legislated for, in almost all, the data about what happens, how people die, is not there, or it's very, very patchy and incomplete. The doses utilized are much, much higher than would ever be utilized to treat someone. For example, the most commonly utilized oral regime comprises diazepam, 1 gram. 10 milligrams is quite a lot. Digoxin, 50 milligrams. We would normally use 0.5 or 0.75 micrograms. And these are all in addition, and morphine up to 3 grams, amitriptyline, and absolutely massive doses of phenobarbital, 9 to 13 grams in one administration. Worldwide, there's no agreed drug combination for oral or intravenous administration. There's no recent research about drug regimens and outcomes. The last study was over 20 years ago. And perhaps it's no surprise that therefore no drug regimen has ever been approved by a regulatory authority. Let's turn to some of my thoughts on the bill. So the bill, I believe, is based on misconceptions. Proponents and sponsors of the bill suggest that pain and suffering are inevitable at the end of life. That's far from the case. At the second reading and in the committee stage, there were graphic tales of people dying in extremis, some vomiting their own feces. In reality, that specific problem is incredibly rare, less than once in a career for a doctor like me who specializes in a big center in complex symptom control. And anyway, if it does occur, there are interventions to treat it. As stated in the introduction, I've been a palliative medicine consultant for many years, 33, and I've truly yet to come across an ill person who we can't help. The bill's also premised on the misperception that the timing of death can be accurately predicted. Again, that's not the case. Prognostication is notoriously difficult and notoriously inaccurate, even in the last days or weeks of life, let alone the last 6 months. One group of patients recently analysed, quite a large group, it was found that 50% of those thought to be in the last 6 months of their life outlived it. Sometimes we get it spectacularly wrong, both underestimates and overestimates. And then you need to consider that other people have an irregular or a stepwise pattern of deterioration, which is even harder to predict. Some do have a more linear course, perhaps some people with some subtypes of dementia, but for most people, dying does not have a linear course. It's absolutely impossible to accurately predict who is in the last 6 months of their life, and yet the Leadbitter bill has an eligibility clause about expected to be in the last 6 months of life. Palliative care. It's a strange thing, but I spent my working life specializing in something that almost all healthcare professionals do at least some of the time. There are many healthcare professionals outside specialist teams, care of the elderly services is a good example, who are good at providing palliative care, but that is by no means ubiquitous. If, however, a person has complex symptoms or other complex palliative care problems, they need to see a palliative care specialist. There's a wealth of evidence about how comprehensive palliative care, especially if started early in the course of someone's illness, improves quality of life, helps all people and their family cope better, prevents hospital admissions, sometimes enables people to receive treatments that might prolong their lives that they were previously unfit for. It also saves money. But hospices and palliative care services are already struggling to meet the need. Their funding is, to say the least, precarious. To make matters worse, in those jurisdictions where assisted dying has been legalized, increases in palliative care provision are much less than in countries where it's not permitted. In some, including some Australian states, palliative care funding was diverted to assisted suicide funding. We've got the NHS. That won't happen here, will it? Well, NHS funding of hospices and community palliative care services varies between 11 and 25% of total cost. The remainder comes from cake sales, parachute jumps, voluntary donations, legacies, all great, but not sustainable. To reduce costs, in the last year or two, many hospices have closed beds. Many community palliative care services have reduced their headcount and had to reduce the scope of the patients that they're seeing. And hands-on hospice at home services, which look after people at home over their very last few days of life and prevent them needing unnecessary hospital admissions, are being cut. You might think that hospital palliative care teams, like in the big acute hospital I work in, are exempt. We're not. We're usually NHS funded, as my team is, but the recently mandated savings across acute hospital trusts are already compromising our staffing. Then you need to add that third-party providers are already buying community services from the NHS. They regard palliative care as a cost pressure and they set timelines for disinvesting it. On the other hand, assisted dying services will be income generating, and yet palliative care as a treatment option and medically assisted suicide is no such thing. We've heard from Dan the list, and it was very helpful, of the suggested amendments to the bill. One was to allow hospices to opt out from offering assisted suicide. That too was rejected. Indeed, there seems to be an expectation that hospices will be ideal assisted suicide facilities and services. Kit Malthouse, who's one of the sponsors of the Ledbetter Bill, has suggested that hospices may have their government funding withdrawn if they refuse to offer it. It's happened elsewhere. In Canada, some hospices were actually repossessed and repurposed by the state. And the same could be true for care homes. These are political decisions, not healthcare decisions. Choice is already limited due to paucity of services, and those services are likely to be further eroded if assisted suicide is legalized. And importantly, if palliative care is not readily available to those who need it, there's no choice, and assisted death will likely seem the only option. That's a form of coercion. So in conclusion, if we want to ease suffering at the end of life, then we as a society need to demand our politicians take geriatric care, palliative care, and seriously, as well as other things that are woefully poor at the moment, like mental health services and social care. We need their commitment to overhaul current models of service provision and to properly fund end-of-life care in all its iterations so that it's fit for purpose. Current need is not being met, let alone the future needs of our rapidly aging population, and those living much longer with severe chronic illnesses than was previously the case. There's a really pressing need to improve care, not to change the law. Thank you.
If you like what you saw on the video here, make sure you click on here because we need to carry on the work we're doing, and the way we do that is through our membership. We'd love you to join. Click on here, see what you can do, and be part of making things better for all of us together. Thank you.